Hi, if you want help with cocaine withdrawal, then you'd better stay right here. So, cocaine withdrawal. Now, I need to state a disclaimer. What I'm going to say next is intended for general educational purposes only and does not constitute specific medical advice. If you or someone you know needs help with cocaine withdrawal, you need to see your own doctor or your own addiction specialist to get specific advice for you. Having said that, let's talk about cocaine withdrawal. So we know from various previous discussions that cocaine is a short-acting psychostimulant with strong reinforcing properties. The withdrawal from cocaine is not medically dangerous, but it can be psychologically distressing. So it's not dangerous, but it's definitely unpleasant. And because it's so unpleasant, effective withdrawal management is crucial for people stabilizing off cocaine and going forward into cocaine relapse prevention. So if we look at the specific timeline of cocaine withdrawal, there are three phases: the crash phase, the withdrawal phase, and the extinction phase. The crash phase starts about 6 to 12 hours after last use and can last 1 to 2 days. And it's characterized by feeling very tired and very sleepy, and also feeling very low and not able to enjoy anything, anhedonia. And people can experience an increased appetite or increased cravings during this phase. After that, then you get this kind of agitation phase where you get very irritable. And this is the point where people leave hospital and go and use again. This can last 1 to 3 weeks and is specifically characterized by irritability, low mood, anxiety, insomnia, poor concentration, and persistent craving. And then we move to the extinction phase, and this can last months, and you get lingering cravings, low motivation, sleep deprivation, and you're at risk of relapse there. So really, whilst the symptoms of cocaine withdrawal are quite short-lasting and are not dangerous but are psychologically distressing, we need to understand that certain symptoms for cocaine withdrawal can last months, and in particular the craving and the insomnia. So it is thought of as a short-term phenomenon, but it does have specific long-term tails. So how do we manage cocaine withdrawal? Well, first of all, like any management of any withdrawal, we need to provide general supportive care. So you can manage it in outpatients, and people can withdraw from cocaine in the community. But we would recommend admission to hospital if there's associated mental health problems, if people are feeling suicidal, or if people are feeling unsafe. And supportive strategies include psychoeducation, so education about what to expect. That in and of itself can reduce stress and anxiety. So sleep hygiene measures, nutrition and hydration, regular clinical review, and key is a calm, low stimulus environment. So when I'm thinking about cocaine withdrawal, I actually think about the 4-3-2-1 rule. So this is for the management of cocaine withdrawal for inpatients. So I recommend 4 sets of observations a day, 3 meals a day, 2 passing urines a day, and 1 bowel movement a day. So really it's all about maintaining physiological comfort. Now, specifically, there are certain medications that we use to treat the distress associated with cocaine withdrawal, and the most commonly used drug is diazepam. So we need to emphasize that diazepam for cocaine withdrawal is only for short-term use, and it's there to help manage agitation, anxiety, or panic, and acute insomnia. We would normally go to 40 milligrams a day as a maximum and then start tailing that over the next 5 to 7 days. And so you'd expect no diazepam on day 7 and thereafter. So an example of a diazepam tapering schedule would be on day 1, 40 milligrams total. So that would be 10 milligrams 4 times a day. Then on day 2, you drop that down to 35 milligrams. So you might do 10, 10, 10, and 5 at night. Day 3, you drop down to 25 milligrams, so you might do 10, 5, 5, 5. Day 4, you would drop down to 15 milligrams, so you would do 5, 5, 5. Day 5, you do 10 milligrams, you do 5 milligrams BD. Day 6, you just do 5 milligrams, and then you'd stop by day 7. So there's an example of a starting dose of 40 milligrams a day that gradually tapers down to 0 by day 7. It's just an example. It's not prescriptive. If you have your own way of managing a cocaine withdrawal using diazepam tapering, then it's up to you. The key point, though, during this treatment phase is that you need to tailor the dosing to patient symptoms, and you need to review the patient every day. And using diazepam for the management of cocaine withdrawal is also problematic in people who have prior ongoing benzodiazepine dependence, and that would tend to suggest, in those patients, we would tend to suggest that we should admit those patients, and we would have to tailor the diazepam schedule, taking into account pre-existing levels of dependence. Now, you can use other medications purely for supportive symptom management. So you can use mirtazapine, for instance, to help with anxiety or insomnia or appetite loss, and definitely a good option for people with sleep or mood disorders. And the range you would use just for symptom control would be 15 to 30 milligrams at night. You can use olanzapine for agitation, or in fact specifically for cocaine-induced psychotic disorder, if that emerges during treatment. And you would use probably 5 to 10 milligrams orally as needed. But again, that really would only be as an inpatient or in a supervised medical setting or supervised psychiatric setting. And similarly, you could use risperidone, another antipsychotic, 0.5 to 2 milligrams per day. So I have to emphasize the use of antipsychotics is really for extreme agitation or psychosis and very short term, unless you've got a psychotic disorder, in which case you'd have to consider it in the longer term. So having successfully detoxed someone, we need to start thinking about discharge planning. It's not enough simply to say, there you are, you're detoxed, off you trot. We need to plan care in the early withdrawal phase, and this includes linkage to other AOD counselling or rehabilitation services, connection with mental health services, safety planning and relapse prevention, peer support, e.g. Smart Recovery or the 12-step programs such as Narcotics Anonymous, ongoing psychosocial support such as help with housing, help with employment, and in particular, ongoing transfer of care in a relationship with a general practitioner. I can't emphasize enough that you need a good GP to help you through the longer term. And the reason why you need a good GP is because you need to prevent relapse. So relapse is very common, and we'll discuss the relapse rates in a moment. But when we're thinking about relapse prevention strategies, we need to consider psychological talking therapies such as motivational interviewing, cognitive behavioral therapy, contingency management, group therapy or peer support therapies, and assertive outreach. And I would make the point that contingency management, which is effectively rewarding people for behavioral change, and in the case of cocaine withdrawal or cocaine use disorder, it is abstinence. This is the most evidence-based intervention that we have at this moment in time. But it's a very difficult sell, especially to make to potential funders or insurance companies, to actually say to people, to say to these individuals, look, we're going to help people with cocaine use disorder, and we're going to pay them to remain abstinent. That's a difficult sell, but if you can do it right, it's got the best evidence for efficacy. Everyone wants to know, is there a pill that I can take to reduce my risk of relapse for cocaine use disorder? At this moment, there is no specific pharmacotherapy that is licensed for cocaine use disorder, relapse prevention. However, some medication work for some people some of the time. And so if you are experiencing cravings or impulsivity, you might want to consider topiramate. If you're experiencing poor concentration or fatigue, you might want to consider modafinil. If there's concomitant alcohol use with cocaine use, then you might consider disulfiram. People experiencing low mood or cravings might benefit from bupropion. Naltrexone can reduce the rewarding effect of cocaine in the same way that it reduces the rewarding effect of alcohol, and so that might help. And there is emerging evidence that dexamphetamine as a replacement therapy may help, in particular lisdexamphetamine, Vyvanse. But again, this is very much emerging evidence and is certainly not approved for use in cocaine use disorder. So effectively, there is no TGA-approved medication for cocaine use disorder. Any use of these medications should be under specialist supervision, and any prescribing needs to be associated with a clear and frank discussion around the risks of using the medication, the side effects, and the potential benefits. And really, if it's not working, then stop it. We then need to understand the context of the desire to provide a pharmacotherapy, and that is the relapse rates, the prognosis. So cocaine use disorder is associated with a 40 to 60% 3-month relapse rate. And this is the highest risk period within the first 3 months and is associated with significant cravings and mood instability. And then by about 6 months, if you're not engaged in care, then you have between a 70 to 80% chance of relapse. And at this point, if you can engage with care, your risk of relapse does actually reduce. And at the 12-month mark, the year mark, the unsupported relapse rate is up to 75 to 85%. But with support, 15 to 25% of people can actually achieve sustained abstinence. So again, this emphasizes the point that the management of cocaine is not just the management of cocaine withdrawal, but it's ongoing psychological support to help people perhaps repeatedly go around the cycle of change and have multiple episodes of withdrawal and multiple episodes of attempting recovery and abstinence. And eventually people will get across the bar and achieve abstinence, or achieve recovery rather, which is defined by the World Health Organization as abstinence for more than 5 years. So in the longer term, the prognosis is quite good. So the WHO defines recovery as abstinence for more than 5 years for any drug, and states that half of all people seeking help will ultimately achieve that. And we know that in resource-rich settings, that about more than 70%, about 72% of people will actually achieve recovery. So in the short term, the cocaine relapse rates are a little bit daunting, but in the longer term, the news is good, and I can look everyone in the eye and say, look, not only is your recovery possible, but is also probable. So to that, we need to actually understand the prognostic factors that will actually increase your chances of a successful withdrawal followed by a meaningful recovery. And the key thing is ongoing engagement with treatment. You must keep in touch with every support that you've got, including your treating medical team. Having stable housing, having stable relationships is also very good for your prognosis. Having appropriate mental health support and participating in peer support groups. So Narcotics Anonymous or the Smart Recovery Program or any AA program is absolutely crucial to long-term recovery. So to conclude, cocaine withdrawal is unpleasant, but it is not life-threatening. It lasts for about 5 to 7 days, but lingering cravings and insomnia can persist for months afterwards. And withdrawal is only the first step in the journey of recovery that needs ongoing psychosocial support to overcome an early but significant relapse rate. That's all for today, folks. My name is Dr. Ferghal Armstrong, and this has been Cracking Addiction.